Welcome. I'm Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology, and I am welcoming you to Rheumatology Virtual Grand Rounds. Today, it's a great pleasure for me to introduce my good friend and colleague, Brian Mandell, who's a professor of medicine at the Cleveland Clinic Lerner College of Medicine, and has had a career-long interest in crystal-induced arthropathy. And everyone who's listening to this, who's interested in this topic, knows that this whole field has undergone some revitalization the past few years with new drugs, new approaches, more aggressive tack towards management. So, Brian, get us up to date.
Hi, I'm Brian Mandell. I'm the professor and chairman of academic medicine at the Cleveland Clinic and a practicing rheumatologist. And what I'd like to do today is discuss the management of hyperuricemia. This is going to be a case-based discussion, and I think first it's appropriate for me to show you the disclosures of consultancies that I've done in areas related to gout-related therapies. And as you can see, I've done several consultancies. I don't do any promotional talks. And I'll hope that you'll agree with me by the end of this that my participation in this type of activity leads me to have a greater understanding as opposed to a concept that I'm out there selling any specific drug. So let's get into this with the first case study, who's a 48-year-old construction machinery driver who comes in for a follow-up visit. You've treated him for hypertension as well as tophaceous gout, and he feels good. His last attack of gout was mild. It was over 6 months ago. It resolved promptly with just taking a few doses of over-the-counter naproxen. His only new problem is he describes some poor sleep, which he attributes to the stress of decreased work and a reduction in his health care benefits due to the economy. He'd obviously like to reduce his medications, and he suggests that this is a good idea to do several times during the visit. Prior to his current therapy, he'd had several severe crystal-proven attacks of gout per year, causing him actually to miss work. His current medications, enalapril twice a day, hydrochlorothiazide 25 milligrams, colchicine 0.6 twice a day, allopurinol 300 milligrams daily, and a recent addition by his primary care physician of zolpidem 10 milligrams at night for sleep. His blood pressure, 136/76 as you check, and he's had a few olecranon non-tender movable pea-sized nodules. He's got bilateral bunions, which are not particularly tender. He has no gallop or edema. On cardiac exam, his lungs are clear. On undilated retinal exam, he has no changes of hypertension that you recognize, and the rest of his physical exam is really quite normal. On laboratory review, he has a normal CBC, AST, glucose, and his creatinine is 1.4. His serum urate is 7.2. The laboratory normal is less than 7.8 milligrams per deciliter. His LDL was 114. His HDL was 28. So looking at the choices here, you suggest A, stop his colchicine, continue the allopurinol 300 milligrams daily, let him use naproxen as needed for acute attacks. B, continue the colchicine, continue the allopurinol 300 milligrams, naproxen as needed for acute attacks. C, stop his colchicine, stop his allopurinol, use naproxen as needed. D, stop his colchicine, increase the urate lowering therapy, use naproxen as needed. Or finally, continue his colchicine, increase his urate lowering therapy, and use naproxen as needed. So make your choice here as to what you would recommend. So the first thing I think we need to discuss when we look at these choices is how do we really define hyperuricemia? And what you see on this slide is an older but probably still appropriate distribution curve of the serum urates in both men and women. We see that men in general have higher serum urates than women, although postmenopausally women catch up, probably due to the loss of estrogen as a uricosuric hormone. The laboratory normal is indicated in the red bar at approximately 7.8 from this laboratory, and anything above that is termed laboratory hyperuricemia. However, the concept that is really very important in the management of patients with hyperuricemia and gout is that urate tends to crystallize in biological fluids at a level of about 6.8 milligrams per deciliter, which I would term biological hyperuricemia. And if we compare that number with what the laboratory says, you see this big block of green here that says that patients can be biologically hyperuricemic, which means they may be precipitating urate around their joints and their periarticular structures, even elsewhere, but still be in the laboratory normal range. So what we think is biologically relevant hyperuricemic is not necessarily what the laboratory tells us is normal. So despite the fact that our patient hasn't had a gout attack in greater than 6 months, he still has tophi. Those are what those little pea-sized nodules are in his olecranon bursa. And this really reflects evidence of a very large urate burden still remaining in his tissues. And as long as he has that significant urate burden, he's still at risk for additional attacks until these actually are dissolved and are removed from his body. And that's obviously very important to a guy who's working, concerned about his ability to continue working, and even loss of his job. So this is a very important issue for him, that he not have continued attacks that could make him lose work time. Now, his serum urate is 7.2. Then despite the fact that this is the normal range, as I just showed you, this is really above the saturation level of urate in body fluids. So he really needs additional urate-lowering therapy, as our goal remains to completely stop attacks over time going into the future. So if we look at what's the relationship between serum urate and the resolution of tophi and the decrease of attacks over time, here's a study that looked at 63 patients with tophaceous gout who were followed for 5 years. They were treated with either allopurinol or benzbromarone, a drug that's not available in the States, which is a very potent Uricosuric, and they were given either or both of these to lower the level of serum urate. And what we see on the graph here is plotted as the mean serum urate that was achieved with either of these therapies, and the speed at which measurable tophi were diminished on measurement. And you can see if you drop the level of urate to less than 4.0 milligrams per deciliter, you see that the measurable decrease in tophi is actually more than a millimeter per month, which is quite a significant rate. So the lower the urate, the more rapidly you can deplete the body of excess urate, even measured by disappearance of tophi. Now, in the next slide, you can see here from clinical trial data that as you lower the urate to less than 6 milligrams per deciliter, or lower it but not to that degree, over the course of a year, the attack frequency is clearly decreased compared to the baseline, and the lower the serum urate, the lower the attack frequency is. So this is really, in this gentleman, where we want to be, is we really like to decrease that likelihood of a flare over the course of a year, hopefully to zero. And the lower the urate, the more likely we are to be able to accomplish that. Now, another part of the clinical trial that I'm showing you here, and this was instituting either Febuxostat or Allopurinol into a group of hyperuricemic patients who had frequent attacks of gout. And I'm lumping together the two drugs because I don't think it makes any difference which drug they were on. The message is if you lower the serum urate, you will, by a year, decrease the attack frequency. What you can see here is in the period of time from 8 to 16 weeks, an increase of flare response following the withdrawal of colchicine or naproxen prophylaxis. So what you can see is really the benefit of having prophylaxis on board when introducing urate-lowering therapy. Now, here's a study, a separate study, that looks at the effect of continuing colchicine over a period of time. And what you can see here in blue is patients who were started on allopurinol and given placebo as a prophylactic anti-inflammatory. And you can see that attacks were very common within the first 3 months of instituting hypouricemic therapy. And even at 6 months, there was still a significant rate of flares in gout attacks following allopurinol introduction. However, in patients who were treated with colchicine as prophylaxis, that flare rate was dramatically decreased, demonstrating that the use of colchicine in low doses, once or even twice a day, was effective at preventing these mobilization attacks, as they're called, following the initiation of urate therapy. And it's important to note that these flares continue even after the target of perhaps 6 milligrams per deciliter of urate is reached, because it really takes time to get rid of these urate deposits, even when the serum level is exactly where we want it to be. So for this gentleman, I think the most appropriate response at the time of this visit is to continue the colchicine as prophylaxis and increase his urate-lowering therapy. And he can use naproxen for flares as needed, but the idea here is we really want to lower that urate to at least 6 milligrams per deciliter or less to prevent attacks of gout in the future. With his desire to decrease his medications overall, we could try to decrease his colchicine to 1 a day instead of 2 a day as prophylactic therapy. When looking at the clinical trial data, as I mentioned, in this clinical trial, colchicine 0.6 once a day was about the same as naproxen 250 milligrams twice a day as a prophylactic against the flares that could come from urate-lowering therapy with allopurinol or Febuxostat. And when we make these decisions, we need to think about the side effects and comorbidities of prophylaxis. Someone who's given NSAIDs as a prophylaxis, we might want to consider using a proton pump inhibitor as prophylactic against GI toxicity. So we may wind up using several therapies in some patients to try to prevent those mobilization flares. Now, twice-a-day colchicine may, in fact, be better than once a day. We need to pay attention in that situation if we're going to use twice a day to the presence of chronic kidney disease, which would require the dose adjustment to a lower dose of colchicine. And we need to think about drug interactions with colchicine. But mainly, we need to be cognizant of the fact that colchicine in many pharmacies costs approximately $5 per pill at the current time. Now, financial assistance is available through the company. However, not all patients are able to negotiate this, and we do need to be cognizant of the cost considerations. Other options for prophylaxis when starting allopurinol or other urate-lowering therapies, steroids, there's very little data on this, but really not ideal to side effects of chronic corticosteroids. Interleukin-1 directed strategies have clearly been shown to be effective in several clinical trials, not yet approved by the FDA for this indication, and obviously there's significant cost for these medications. Now, I would consider prophylaxis for at least 6 months after the last attack or until all visible tophi are resolved. And this is the setting, again, of when I'm introducing urate-lowering therapy to a patient in hopes in the long run of stopping flares from happening. So if we go back to our 48-year-old construction worker with olecranon tophi, hypertension, a history of several gout attacks per year, he had normal liver enzymes and a creatinine of 1.4. If we were just going about starting his allopurinol therapy as a urate-lowering drug, what should be our initial starting dose? 50 milligrams, 100 milligrams, 200 milligrams, or 300 milligrams? What would you generally start this gentleman on? So there are several principles and pitfalls in treating hyperuricemia, and particularly when we initiate the therapy. The first is, as I mentioned, the initial lowering of urate elicits these mobilization attacks of gout, and we need to be cognizant, and we certainly need to make our patients aware that this may happen. And it turns out that the likelihood that mobilization attack will happen is related to how low the initial urate is dropped. And this is, again, from that New England Journal paper looking at allopurinol or Febuxostat initiation in patients with hyperuricemia and gout. And you can see that the patients who had a dramatic response to the urate-lowering therapy and dropped their urate level very low to less than 4 had almost a 45% flare response, as opposed to those who had it lowered some, but only to a level of approximately 7 initially, where the rate of flare was 25 to 30%. So the drop in urate correlates with the likelihood of getting a flare. So for this reason alone, which really translates into patient compliance with the medication, I would recommend starting at a very low dose of allopurinol, either 50 milligrams or 100 milligrams. The 100 milligram tablets of allopurinol can be broken in half for this purpose. So our 48-year-old construction worker with his tophi, hypertension, and history of several gout attacks per year, I would say when starting therapy, should start on 50 milligrams, which is half a pill once daily. So if we go back to where he is now, as he's visiting us in follow-up, his current medications are indicated here: enalapril, hydrochlorothiazide, colchicine, and allopurinol. His blood pressure 138/76. He has those few nodules. His labs are shown here again, and his serum urate is 7.2. We continued the colchicine for prophylaxis and continued the allopurinol, but this time was raised to 400 milligrams daily, given as 300 in the morning and 100 in the evening. Several weeks later, the serum urate was checked, and it had decreased to a level of 6.8, above still our target of where we'd like it, I think, to be. So to lower his urate further, you suggest increasing his allopurinol to 500, continue the allopurinol at 400, but stop his hydrochlorothiazide, continue his allopurinol at 400 and start a urate-restricted diet, stop his allopurinol and switch to Febuxostat at 40 milligrams daily, continue the allopurinol at 400 and add Febuxostat at 40 milligrams daily. What would you choose to do? So let's go back and look at a little bit of data on the dosing of allopurinol. So here is a study of about 50 patients with gout who were given 300 milligrams of allopurinol daily. And if you look at this group as a group, the mean reduction went from 8.6 to 5.8, which looks great. However, if you look at the individual patients, 47% of them had an inadequate response. If we say an adequate response is getting to the target level of 6 milligrams per deciliter or less. Here's the breakdown of the dose of allopurinol it took to do that, and you can see that about half of patients took 400 milligrams or greater to get to that level of 6, which is what we think is the most effective dose ranging to really prevent attacks of gout in the future. So what about hydrochlorothiazide? Well, we all know from pharmacology that hydrochlorothiazide increases serum urate, but we need to think about some therapeutic considerations before considering modifying hydrochlorothiazide in patients with hypertension and gout. So coronary disease, incredibly common in patients with gout, as is the full components of the metabolic syndrome. Hypertension, probably the major comorbidity in patients with gout, contributing to coronary disease along with chronic kidney disease. And if we look at the population of patients with hypertension in the United States, we don't do well at treating this. It's too often undertreated, yet it has a significant contribution to cardiovascular morbidity and mortality, and a high percentage of patients need greater than 2 drugs to control their blood pressure, which includes a diuretic such as hydrochlorothiazide. The thiazide effect on serum urate seems to be dose-related. It is modulated by the GFR, and thus it is hard to predict exactly what the response of any dose of hydrochlorothiazide is on the serum urate. But I've pulled here from several clinical trials of antihypertensive involving hydrochlorothiazide. What is the serum uric acid increase in milligrams per deciliter based on the thiazide dose. And as you can see, with thiazide of 25, looking at these pooled study results, it was less than 1 milligram per deciliter rise in the serum urate. A recent paper in Arthritis and Rheumatism of 171 patients with hypertension who were started on thiazide in various doses, they increased their serum urate only by about 0.8 milligrams per deciliter. So it is not a very large increase in the serum urate. I would not stop this gentleman's hydrochlorothiazide. His blood pressure systolic at 136 is not yet ideal, and taking the thiazide away is not going to help his blood pressure control, will clearly worsen it, and it's not going to give enough response in the serum urate that would avoid me still needing to do something else to his urate-lowering therapy. So what about diet? If we look quickly at the biology of uric acid in the body, we see the overwhelming majority of it comes from endogenous purine synthesis and breakdown of tissue nucleic acids. Only about a third actually comes from dietary purines. And this goes into uric acid synthesis, and really the level in the serum is controlled predominantly by kidney excretion, not really by production or dietary intake. And this is at the mercy of renal transporters, which can either increase or decrease the serum concentration of uric acid, and this is controlled both by genetic factors as well as by drugs and other electrolytes circulating in the serum at any given time, which modify the renal transport of uric acid out of the kidney. So it is really the renal transporter function in probably 90% of patients or more that winds up in giving patients their hyperuricemia. So dietary lowering of serum urate, we need to remember that most circulating urate is from endogenous sources, not exogenous. Renal excretion is the primary dictator, and urate-restricted diets are really not palatable to most patients, and really, even if adhered to rigidly, will change the serum urate level only slightly. Food additives, cherry juice, and vitamin C have a small effect. Beer and organ meat actually have a greater effect and probably should be limited, and we need to counsel patients about that, and that includes alcohol-free beers. Dairy supplements may have some benefits, both on urate as well as anti-inflammatory effects, and most certainly we should advise patients to avoid any foods or liquids containing fructose corn syrup. This has major effects on the serum urate. Weight loss is certainly beneficial, and we need to pay attention to comorbidities when recommending these dietary changes. A quick look at these renal transporters that come into play predominantly in the proximal tubule. We see the primary transporter, the Urate1, which is the target for probenecid, a drug that is available as a Uricosuric in the United States. There are several new drugs under clinical development which will be far more potent than probenecid. But right now, the Uricosuric therapy approach in the United States is really secondary to an inhibition of xanthine oxidase, which tends to be far more effective. Now, Febuxostat is a newer drug, recently approved. It certainly is effective at lowering the serum urate, and I showed you some data combining it with allopurinol, not in the same patient, but in the same clinical trial. It is a different structure than allopurinol. It inhibits approximately the same active site, so you probably don't want to use allopurinol in conjunction with Febuxostat in the same patient. It comes in 40 or 80 milligram tabs. It's not available in a very low dose, which is where I would like to start people for the same reason that I say I would like to start people with allopurinol at 50 milligrams. In the U.S., it's far more expensive than allopurinol. You see some rough estimates here from our own pharmacy comparing 40 or 80 to allopurinol at 300 milligrams. It is not yet demonstrated to be more effective than appropriately dosed allopurinol, which means that if we look at the patient's serum urate and escalate their allopurinol to get to the target level that we want, it has never been compared in clinical trials that have been reported yet. It is more effective than 300 milligrams, but as I already showed you, the 300 milligram dose of allopurinol is insufficient in most patients to control their urate levels. Most importantly, Febuxostat is tolerated by most allopurinol allergic patients, so we now have an option in those patients. I personally reserve its use in allopurinol intolerant patients or unresponsive, which I would say is at least 800 milligrams a day of allopurinol before switching it to the more expensive therapy. Here's an abstract that looked at 12 of 13 patients who had had significant allopurinol adverse reactions, demonstrating their ability to tolerate Febuxostat without hypersensitivity reactions. And here's just a listing of 9 patients that we saw who had had significant reactions to allopurinol, able to tolerate Febuxostat. So although some allergic reactions to Febuxostat have not unsurprisingly occurred, in general this is a very well-tolerated therapy in patients who are allergic to allopurinol. So my next question for you is, how long do you usually plan to continue urate-lowering therapy? Forever? Until about 5 years after attacks stop, independent of tophi? Until the tophi are gone and no attacks have occurred for about 5 years? Or until no attacks for 2 years? How long do you usually continue urate-lowering therapy? So there actually is a little bit of trial data now that looks at this. So they took 211 patients with gout, 25% of whom had tophi. They treated the urate to less than 6 milligrams per deciliter for 5 years. If the patients had tophi, they treated them for 5 years after the tophi were all gone. Then they stopped the urate-lowering therapy to see what happened. And what happened was, over time, some of these patients had recurrent flares in their disease. By 4 years, about 30% of folks had recurrent flares of their gout. And it turns out the likelihood of developing a recurrence was related to how high their urate level bounced back up to. So if the urate-lowering therapy was stopped and they still had a serum urate less than 7, they were not likely to develop an attack of gout over that 4-year period. But if their levels bounced back much higher, which means that nothing had changed biologically in the patient over that period of time, they were likely to have a flare, and the time to the flare was clearly related to how high their serum urate went back up. If their serum urate level bounced up to greater than 9, they were going to have another attack of gout, and the gout attacks would start to happen more regularly over a fairly short period of time. So for most patients, urate-lowering therapy is in fact a lifelong therapy. What about truly refractory gout? This is the hand of a patient who was 24 years old and had a family history of severe gout. Even on allopurinol, 1,200 milligrams a day, his serum urate level was 8.1. And I note that 1,200 milligrams is higher than the FDA-approved dose for this. Even adding probenecid, his serum urate level only dropped to 7.8 to 8. And that included he was on chronic colchicine, prednisone 10 to 40 milligrams a day, intermittent to even daily NSAIDs, still having attacks all of the time. Switched him to Febuxostat up to 240 milligrams, again higher than the FDA recommended dose. His serum urate was still only 8.4. Adding a Uricosuric only dropped at 8.1. This is clearly a case of refractory gout. And this is the indication to consider the drug Pegloticase, which is an intravenous infusion of the enzyme uricase, which will dissolve uric acid and uric acid deposits in the body, converting uric acid to allantoin, which is more soluble and excreted. So the clinical trial data summarized by Sunday in JAMA in 2011 talked about 85 patients who received 8 milligrams every other week for 6 months. The baseline uric acid in these patients was greater than 8. They all were having frequent attacks of gout prior to therapy. A responder was defined as a uric acid less than 6, 80% of the time, And it was very effective therapy for those who were able to stay on it. Unfortunately, 13 out of 46 patients were forced to withdraw, mainly due to mild or moderate infusion reactions. But if you look at the data here, you can see that almost 50% in an intent-to-treat analysis of patients with Pegloticase dropped their urate to less than 6, and by 3 to 6 months, the Pegloticase flare rate was less than placebo. Not surprisingly, when the therapy was first initiated, the flare rate went very high, and that's coincident with what we talked about before, that dropping the serum urate is likely to precipitate attacks of gout. Now, when using Pegloticase, there are several things we need to keep in mind. It's a pegylated enzyme, which was designed to be less immunogenic and last longer in the circulation. But oddly enough, it turns out that the pegylation component of the molecule actually does generate some antibodies against it, and patients who develop those antibodies become resistant to the drug, unresponsive to the drug, and those are the patients who develop infusion reactions. Those patients who don't develop the antibody, it's very effective, and the serum urate frequently will drop down to either unmeasurable or less than 0.5 milligrams per deciliter for at least the 2 weeks between infusions. Tophi would resolve even over the course of several months. Not surprisingly, an incredible expensive therapy, about $2,000 for an 8 milligram single dose. High flare rate, as I mentioned, and antibodies are really the major issue with this drug. Then patients who develop high titer antibodies, most patients develop some antibodies, are the ones who develop resistance and infusion reactions. And it turns out that the loss of efficacy and the infusion reactions are those with the high titer antibodies. And so these patients can actually be predicted, because if you don't drop your serum urate level following each infusion, you're more likely to develop an infusion reaction, and the drug should just be discontinued. So finally, let me ask you about a 52-year-old surgeon, different than our initial patient, who's referred to you for management of gout, and his urate level is 8.6. There was never a joint aspiration. Hand and foot x-rays reveal osteoarthritis of his thumbs and great toes. You elicit no history to suggest acute attacks of gout in the past. He has no other medical problems. He self-administered NSAIDs, which have helped the foot and toe discomfort, but you notice creatinine is 2.8, which was 2.4 last year. Would you recommend urate-lowering therapy for him, yes or no? So this is not an issue of really gouty arthritis, because based on the history, he probably doesn't have gouty arthritis. But what about his kidneys? And this is certainly an up-and-coming area of controversy and of enormous interest. The treatment of serum urate with urate-lowering therapies, not to prevent gouty arthritis, but to prevent other comorbidities which have been associated with hyperuricemia. And if we look at the progression of chronic kidney disease, I'm just going to highlight 2 studies here. Here is a study that looked at 21,000 patients over a prospective 7-year history and asked what's the likelihood that their GFR is going to drop below 60. And they broke these patients into several groups with what was defined as a normal serum urate, a urate of 7 to 8.9, or a uric acid circulating of greater than 9. And what they saw was associated with the serum urate was a significant relative risk of developing chronic kidney disease over this same period of time. A second study, which was much smaller, 54 patients, was an interventional study that looked at folks who had 0.5 grams of proteinuria or creatinine greater than 1.35 but less than 4.5. And they said, what will happen if we lower their serum urate with allopurinol? And here are the data plotted out by looking at those who developed a rise in their serum creatinine by greater than 40%, whether they were given allopurinol or given control, which is no urate-lowering therapy, and just followed. And what you see is a significant diminution in those who progressed to chronic kidney disease who received allopurinol therapy. Now, this treatment would obviously be off-label, and I don't think that we have adequate amount of data to support this as routine practice right now, but this is certainly provocative information, and I think in the future is likely to influence our clinical practice. So in summary, some clinical points of note about managing hyperuricemia. The laboratory normal is not always low enough to be biologically normal in patients with gout. Our target serum urate for those needing urate-lowering therapy to control gout attacks or tophi should be significantly below 6 milligrams per deciliter, so we need to titrate the dose of therapy to get there. The initiation of urate-lowering therapy can provoke acute gout attacks, which can be prevented by anti-inflammatory therapy with colchicine, NSAIDs, or even anti-IL-1 directed therapy in very selected patients. I don't believe that low-dose thiazide or low-dose aspirin should be discontinued in all gouty patients. We need to look at the whole patient, not just their urate and their gout. Accurate diagnosis of gout actually does matter. So I think before putting someone on urate-lowering therapy for management of arthritis, we should be certain that they have gout and not perhaps an alternative diagnosis such as pseudo-gout. Treating to a target serum urate level of less than 6 will reduce attacks and tophi, but you need to monitor that serum urate level with therapy. We need to dose allopurinol appropriately to escalate that dose to achieve the target. We need to consider prophylaxis, and for those patients who have suffered allopurinol allergic reactions, Febuxostat is a very reasonable and very effective alternative therapy. If attacks happen, we need to treat them aggressively, and the choice of therapy really is dictated by the presence of comorbidities in those patients. Treating asymptomatic hyperuricemia to prevent the comorbidities, clearly insufficient data right now, but this is something that is going to be on everybody's radar screen, and it's a very provocative and intriguing area, so you need to stay tuned for that indication. And with that, I will close this discussion of hyperuricemia and gout.
Thanks, Brian. That was really terrific. You know, I'm trying to get this in my head. What are the take-home messages for the best practices of managing hyperuricemia and gout? And the first is that we need to pick the right target for uric acid. We're not, can't be wimpy about this. We have to be 6 or less, and the lesser the better. The second point that I got from your talk was that allopurinol is our friend. This drug has been around for a long time. I think many of us are timid about using it. I can see from your practice, and I know from your practice, that you often go up to doses that would frighten many clinicians. But if it's done slowly and the patients are monitored, you can reach that uric acid target. Over and above that, there are a lot of different options available for people who are intolerant, Febuxostat, who don't make that target. And then finally, while we didn't talk too much about it, Pegloticase for those really bad people with tophaceous gout. The other thing that I got from you is that as we get more aggressive in treating hyperuricemia, we're going to see more paradoxical gout attacks. So our prophylaxis has to be sound, and it has to have some duration to it. And finally, thanks for the tips on managing things such as aspirin and blood pressure. There's going to be a lot more on this topic along the way, and we look forward to having you back on Rheumatology Highlights Report.